Good evening to one and all. I am Dr. Pallavi. The topic of my presentation is an acute presentation of thyroid eye disease in a male with euthyroid state. Thyroid eye disease is a complex orbital inflammatory disease which is sight-threatening, debilitating and disfiguring. TED is also known as Graves' ophthalmopathy, named after Robert J. Graves, an Irish physician who first described thyrotoxicosis in a woman presenting with goiter, rapid heartbeat and exophthalmos. The overwhelming majority of TED cases are associated with hyperthyroidism, while the rest are euthyroid or hypothyroid. Risk factors for the disease include female gender, middle age. Smoking is the strongest modifiable risk factor for developing thyroid-associated ophthalmopathy. The signs and symptoms of thyroid-associated ophthalmopathy are varied as its epidemiology and pathophysiology. Symptoms range from watering, eye pain to double vision, and signs extend from conjunctival injection and chemosis to lid retraction, EOM restriction, strabismus, to sight-threatening exposure keratopathy and compressive optic neuropathy. Diagnosis is based on series of investigations including blood levels of thyroid hormones, MRI brain including orbits, enhanced CT brain that shows extraocular muscle enlargement. Treatment is symptomatic in acute phase, and other modalities like orbital decompression as and when required. The case report is a 25-year-old male presented with complaints of swelling of both eyes, pain, photophobia and watering since 3 days. There was no complaints of diplopia. The patient did not give any history of fever or any trauma. There were no similar complaints in the past, no similar complaints in the family as well. He's a chronic smoker since 8 years. On examination, the visual acuity was 6/6 in both eyes. Bilateral mild proptosis with upper lid retraction was noted. Extraocular muscles showed movement restriction, more in infraversion, supraversion, and adduction. On slit lamp biomicroscopy, anterior segment showed severe congestion and chemosis of conjunctiva in both eyes. Rest of the ocular and systemic examinations were within normal limits. The investigations are as follows. The picture of the patient shows severe chemosis, conjunctival injection, upper lid retraction, and mild proptosis of both eyes. This is the MRI section. The term thyroid eye disease denotes typical ocular changes which include lid retraction, lid lag, and proptosis. These changes have also been labeled as endocrine exophthalmos, malignant exophthalmos, dysthyroid ophthalmopathy, ocular Graves' disease, Graves' ophthalmopathy, and thyroid-associated ophthalmopathy. There are various classifications for the same. The diagnostic criteria of TED include combinations of the classical signs, which include eyelid retraction to the level of superior limbus or above along with any of these, thyroid abnormalities, preferably including anti-thyroid antibodies, exophthalmos, optic neuropathy, extraocular muscle involvement, or thyroid function abnormality with one of the following, that is exophthalmos, optic neuropathy, extraocular muscle involvement. The treatment for TED should be multidisciplinary approach involving an ophthalmologist, endocrinologist, a radiologist, and a general physician. The principal aim should be thyroid function control, as this is associated with reduction in the severity of the disease. Systemic corticosteroids are considered and are most effective in this phase. In our case, we administered intravenous methylprednisolone for 3 days, followed by tapering dose of oral prednisolone for a period of 3 weeks. Other agents like cyclosporine, azathioprine, rituximab are gaining popularity and are under clinical trials. Coming to the conclusion, thyroid-associated orbitopathy is a debilitating and vision-threatening disease. Pathophysiology of the disease is yet to be completely elucidated. However, thyroid-associated ophthalmopathy is understood to be an inflammatory process. Activation of pro-inflammatory cytokines results in increased hyaluronan production by orbital fibroblasts, leading to classical manifestations of TAO. As we already discussed, the age, sex, and thyroid state preponderance of thyroid-associated ophthalmopathy. This case throws light on the rare presentation as in a young male of 25 years with eugenical status of the thyroid. Patients with thyroid abnormalities should be screened and educated about the signs and symptoms. A multidisciplinary group including oculoplastic surgery, strabismus surgery, and neuroophthalmy can closely monitor patients for disease progression and implement appropriate medical and surgical therapy. Thank you.